And this is where, this whole concept of giving live microorganisms that once consumed, we're talking about oral bacteria, may have a benefit to the host. And as was also said earlier, we're really limiting ourselves to very specific microorganisms, namely bifido and lactobacilli. The question is then, can we benefit children by giving them, by bringing back some of that immunologic experience that we are not, we have deprived most of our infants of. Importantly, as you also heard, not all bacteria that we eat are necessarily probiotics, meaning they have not shown or been shown to have a particular benefit. Not all have the same benefit or the same level of benefit, and therefore both efficacy and safety when we're talking about probiotics needs to be species specific. We won't go through all those, but it really is a very small number of bacteria, bifido and lactobacilli, of those two genuses. We're not talking about yeast. Saccharomyces is really the only other one that has been well studied for these purposes that have these particular effects. If you look at the literature and just do a simple Medline search today of publications that are done on bifidobacteria, lactobacilli, or now the modern word of probiotics, it's been rather exponential. This has truly exploded. When we talk about those clinical benefits, there is these modifications in intestinal flora. There's by far the best documented clinical benefit associated with many of these oral bacteria is both treatment and prevention of acute diarrhea, particularly rotavirus diarrhea. The data on bacterial diarrhea is very poor. Decreased antibiotic-associated diarrhea, allergy-related conditions. We'll hear more about symptoms that may be associated with intolerance or colic, and you'll hear also more about necrotizing enterocolitis and use in newborns. If you look at meta-analyses of clinical trials, we're not going to go through these. The point here is not that there's a reduction in hours, because this is truly in hours. It's not a huge reduction. What this is showing is that the oral ingestive bacteria can modify the clinical course of a viral illness. The same thing with acute diarrhea, numerous studies, bifidobacteria, lactobacilli strains, and you already heard about atopy. So just to kind of summarize, part of what the concept here is that is behind the clinical data. At birth, through vaginal delivery and through breastfeeding, we get a first good inoculum of bacteria, and every time we feed, we get bacteria orally. This leads to establishing what we would consider a healthy microbiota in these babies and adequate gut barrier function immune response. On the other hand, we have children born by C-section. We have children who are fed sterile formulas. We have children who get antibiotics. And we have children born in the wrong environment and stay in the wrong environment, i.e. our hospitals and NICUs. You can imagine that the flora of a child who's born by C-section and then goes to the NICU is going to look more like the flora of the hospital than the flora of mom or his or her siblings, which is what you would normally expect. This is the whole concept of trying to incorporate back into the diet of infants and children live bacteria that can modulate their immune response. I'm just going to finish the last few minutes by a couple of misconceptions and things that we tend to hear very often with regards to both efficacy and safety of probiotics. Not uniformly efficacious, and indeed, not every bacteria does this. Safety and efficacy of probiotics is not well demonstrated on or studied sufficiently, or they're not ready for prime time, or the probiotic strain did not show an effect in this study. That's an oxymoron, because if it didn't show an effect, then it is not a probiotic. So it is very important that from the point of view of expressing ourselves, and this is the fascinating thing, you look at those studies where I show different strains, directionally they are the same, but the results and the expectations may not have to or should not be the same with one or other strain of bacterium. The probiotics is a category of microorganisms. It's not one. So when we talk about benefits, we're talking about a specific microorganism, a genus, a species, and a strain that has a specific benefit. And we need to speak of probiotics in that way. We can't say probiotics were good for diarrhea. We need to say Lactobacillus rhamnosus, Paracasia rhamnosus was good in reducing the duration of diarrhea. In this case, in some cases, rotavirus. If a benefit wasn't shown in a study, it's not a probiotic, at least for that particular outcome that we're looking at. So efficacy and safety can only be defined for specific organisms, not for probiotics in general. And that's why these generalizations that we hear when we see in editorials are just not right. The other is the issue of safety. And there's, just like with efficacy, each strain should be specified. For safety, we need to do the same thing. We hear generic statements, they're not uniformly safe. Well, nobody expected them to be uniformly safe. We're talking about a whole family of microorganisms, some of which are extremely different one from the other. And obviously, we need to be cautious in terms of how to do it. Or the safety is not adequately documented because clinical trials are not powered for efficacy, which is not a wrong statement. That's actually a very correct statement in the sense that you can hardly ever power any clinical trial for a particular negative outcome. And of course, any bacteria can be pathogenic. I guess that's possible. When we talk about safety, it's not clinical trials. When we talk about the safety of a specific probiotic bacteria, the sources of documentation of safety are very broad, very deep, and very complicated. By far, the most important component of documenting the safety of any bacterium is the bacterium itself. And that means, what do we know about this microorganism? What do we know about its genome? In fact, of that handful of bacteria, that handful, a very few, we have actually the full genome of those bacteria. Do we know what their rate of invasiveness is or their capability for invasiveness? Do we know if they have other pathogenic potential? Do we know if they easily or do not easily translocate? Do they have any undesirable metabolites? Do we have any toxins that they produce, whether we show the toxin or whether we show the genes that can produce the toxin? Are they present in healthy infants? Are they present in healthy humans? Are they present in breast milk? Have we been eating them for a long time? This is by far the biggest component of the documentation of safety, such as when you go to the FDA in this country to talk about the safety of the microorganism, this is what you talk about. The second part of the documentation of safety has to do with what's happened with it. Do we know of anybody really getting sick with this microorganism, whether they've been taking it or not? Because remember, many of these are already existing in the guts of people. And have people gotten sick with these microorganisms, that particular genus, that particular strain? The other big component is history of safe use. And of course, and we can, for a few of these bacteria, we can actually document how many hundreds of thousands, in some cases millions, of metric tons of foods with this particular strain are being consumed every year, and document if really have seen any problem. These are by far the most significant components of documentation of safety. So when we talk about safety for bacteria such as a bifidobacterium or lactobacilli, we're talking about this. And only at the very end, the little cherry on the top is, and in clinical trials we have not seen adverse effects. Because you could never power, if the infection is going to be 1 in 10,000 caused by a microbe, you could never power a clinical trial to do that. You're talking about millions of children in a controlled fashion getting this. So from the safety point of view, clinical trials, we will never document safety, and we shouldn't expect to do that, and we should not use it as an argument against safety, that there are not enough clinical trials. That's a fallacious argument. In summary, development and the modulation of an immune system is dependent of early and continued antigenic and bacterial stimulus. Early interventions with proteins and modulating proteins and bacterial antigens can determine both short and long-term health immune responses, and modifying this intestinal flora, whether it's through probiotics or other means, may provide dietary way to improve intestinal and systemic immune function. And both efficacy and safety for any of these bacteria need to be species specific. Thank you very much.